Well, I think we're getting a good quorum for this presentation. What excellent looks like. Data safety in the new era of glycemic management. We're really proud to work with Leapfrog and be here today on this presentation. I'm Jordan Messler. I'm the Chief Medical Officer at Glytec. I'm a hospitalist trained up in Atlanta at Emory. I came down to the Tampa area about 20 years ago to start a hospital medicine group, and my first projects were around diabetes and glycemic management. And for the last 20 years, I've been working on a variety of projects. Really started doing that locally at my health system and then nationally with the Society of Hospital Medicine. And then in 2018, that work brought me to Glytec, which has insulin software. Really excited to be here with you today, and really excited that we'll kick things off with Dr. Zilbermint. Dr. Zilbermint is an endocrine hospitalist at Johns Hopkins. I've been lucky to know him well the last few years. He's an associate professor at Johns Hopkins University School of Medicine and George Washington School of Medicine. He's the director of endocrine hospitalist program at Johns Hopkins Community Physicians and chief and director of endocrinology at Suburban Hospital in Bethesda, Maryland. You all may be very familiar with him as he started the concept of the endocrine hospitalist program. He started that at Johns Hopkins Medicine and helped save his community hospitals hundreds of thousands of dollars by reducing the length of stay with patients with diabetes. His specialized diabetes team was recognized by the Johns Hopkins Innovations in Clinical Care Award. He's also the recipient of the 2023 ACE Rising Star in Endocrinology and the 2023 Endocrine Society Vygotsky Outstanding Clinical Practitioner Awards. He truly is a national expert in this space in inpatient glycemic management, and we're really pleased to have him with us today. I'll hand it off to you, Dr. Zilbermint.
Thank you so much, Jordan. Thank you, Melissa. Thank you so much to the Leapfrog team for organizing this important webinar. So in the next 30 minutes, I would like to talk to you guys about the importance and urgency of the CMS, the Medicare Glycemic Management Mandate. We'll talk about the new CMS reporting standards, and maybe some of you already know about them, but you maybe been confused about those. We'll also talk about the high impact strategies for the inpatient glycemic safety. We'll talk about, share some safety stories. And finally, we'll talk about how you can leverage the data for compliance, quality, and also performance improvement and patient safety. That's why we are here for. So as we all striving for high reliability organization, like wouldn't it be nice that all of our hospitals would be highly reliable and safe for our patients, especially for those who live with diabetes. I would like to start with the patient safety story. So has anyone heard about the story? So a jury in Baldwin County, Alabama, awarded $140 million. Again, $140 million to the family of women with diabetes who died results of a prescription error. What happened on March 18, 2008, Juna was discharged from Thomas Hospital in Alabama, and her doctor, hospital's doctor, dictated the instructions for the follow-up at the rehab facility. And you know what kind of error was there? Guess what? Instead of 8 units, patient received 80 units of Detamir or Levemir. And unfortunately, this patient developed severe hypoglycemia. She developed irreparable brain injury, and she had a cardiopulmonary arrest and died in March of 2008. So the question for you, and that's the question I'm asking myself every single day, what can we do as people who care about other people who are hospitalized with diabetes to prevent extreme glucose levels? And I want you to ask a simple questions. How do we make sure this never happens in our hospitals? And we all know that hypoglycemia and hyperglycemia happens fairly frequently. So I'll give a minute and perhaps people can type in the chat. If they can't type in the chat, I don't know. What would be your answers? What do you think? What can hospitals do to prevent those extreme glucose levels in the hospital. All right, while you're typing in, we'll move forward a little bit. We'll talk about diabetes in the hospital setting. So we know that 1 in 4 patients admitted to the hospital has a no diagnosis diabetes. Hey, 26% of all of the patients who are coming to the hospital where I spend most of my time, Suburban Hospital in Bethesda, Maryland, they have a known diagnosis of diabetes. And we also know that at least 30% of all of the patients with diabetes require multiple hospitalizations per year. We're talking about 2 to 3 times per year. And the impact of hyperglycemia is enormous. The hyperglycemia associated with 18-fold increase in mortality in the hospital. Ultimately, patients require more subsequent nursing home care. And of course, there's a greater risk of infection. And despite published evidence-based guidelines for improving glycemic outcomes in hospitalized patients with diabetes, those guidelines are not employed consistently, and the reasons are many. I mean, maybe hospitals did not read the guidelines. The American Association of Clinical Endocrinology, the American Diabetes Association, the Endocrine Society, they all publish multiple guidelines. But for some reason, that we know that most of the patients with diabetes are hospitalized for a reason other than glucose management. And it is a possibility that the glucose management does not take such an important priority, even though it has such a huge impact. We also know that diabetes is extremely expensive. We're talking about chronic complications. We're talking about heart disease, complicated pregnancies, more medications. I just had a patient who was admitted to our hospital yesterday. We got a consult from the hospital. It's like, hey, can you please see this patient? He's on 90 units of Glargine and 30 units of Aspart 3 times a day. It was just ordered, but the nurse was not sure whether she should give 90 units of Glargine. Guess what? We jumped in on this case very quickly. We discontinued Glargine 90 units daily order. We actually ordered only 8 units of Glargine instead of 90, and his glucose is fairly well controlled. But remember, when we prescribe more and more diabetes medications, we ultimately cause hypoglycemia. And I hope that there are some hospital administrators are present today on a call. We know that hypoglycemia can lead to increase in length of stay readmission, which ultimately leads to money. Cost of diabetes is enormous. The total estimated cost of diabetes in the United States in 2022 was $412 billion. Again, I'll repeat, $412 billion, including $300 billion in direct medical costs and $100 billion in indirect costs attributable to diabetes. Just think about care for diabetes, care for people diagnosed with diabetes accounts 1 in 4 healthcare dollars in the United States. Can someone name me this country, please? And I'll wait for a second. Maybe someone will type in the chat box. Well, I actually just realized
It's in
I
the
cannot see.
Q&A.
It's in the queue now. So what are the options? Can you read for me, please?
Philippines.
Philippines. Excellent. Excellent. So by the way, I took this picture. My wife and I, before I started the endocrine hospitalist program at Johns Hopkins, we actually went traveling for 6 months around the world. And this is one of my favorite spots in the entire world, the Philippines, the most amazing snorkeling. So if you have not been to Philippines, please go. But why I'm showing the picture of Philippines, because Philippines gross domestic product means total cost of all of the goods, all of the services. It's about how much US spends per year on diabetes. So what is the CMS, or Center for Medicare and Medicaid Services and Medicaid role in the inpatient care setting? We know that the CMS pays for about 66% of all hospital payments, and it largely being from, it's a huge role. It plays in the central role in developing measures that can be used to support a healthcare delivery to its beneficiaries and beyond. And they created so-called inpatient prospective payment system. What it does is, in order to get the increase in operating payment rates, hospitals must successfully participate in the hospital and patient quality reporting programs, and many of your hospitals already participating. So beyond the IPPS, so CMS also sets the payment rates prospectively for the inpatient stays, generally based on the patient diagnosis and services or treatment provided, so severity of illness. It's true for virtually most of the country, except for some of the states like Maryland, where we are under a special Maryland waiver, but maybe we'll talk about it in a different webinar. But let's talk about the hospital and patient quality reporting program. So it's a pay for reporting quality program. What it means that hospitals that do not submit quality measure data or fail to meet all the hospital IQR program requirements are subject to 1/4 reduction in their annual payment update under this rule. And through pay for reporting program or hospital and patient quality program, CMS mandates that certain quality measure data be reported, with resulting reduction in Medicare payments for non-performance up to 25% reduction. And all of this data collected for the program is publicly available for consumers and providers on the Care Compare website to allow more informed decisions about their healthcare. You may have never been to the website, but if you look at the link, and we'll share the slides afterwards, please take a look. Very interesting data. But what we also know is that electronic quality measure programs are those that the automatically extracted from the electronic medical records instead of manually reviewing and summarizing the population level. So the Medicare announced that we are going to start looking at the glucose data. And here's the challenge. Hospitals may not know what they don't know. What I mean is, when CMS announced those hospital harm electronic quality glycemic metrics with glucose less than 40 and more than 300, we've been waiting for this for years. So we announced in 2021, and they said by 2022, the glucometric dashboards have to be created. By 2023, hospitals have to review their glucometrics and decide if each issue to report. The data is publicly available. So data is available publicly already. I'm not sure it's very trustworthy. We got some data from Maryland. We have some hospitals in our healthcare in Maryland who reported 0 hypoglycemia, which very, very hard to believe. But what's more important here, and we'll talk about it in the end, is for those hospitals who don't report the hospital harm glycemic metric for hypo and hyperglycemia, by 2026, in 2028, they're going to face some financial penalties. So I have a little quiz pop up. What is the glycemic target for most of the patients in the hospital setting? Is it A, glucose 40 to 300? Is it glucose to 140 to 180? Is it glucose 110 to 140, or any glucose above 71 is good enough? What do you think? All right. So we have a spread, a little bit of a spread. So the only 3% reported the target glucose is 40 to 300. 43% reported 140 to 180. And 100, I think you can see the poll. Can you see it on the screen right now? I'm not sure. And then 110 to 140, it's 51%. Any glucose below 71 is 3%. So the correct answer is 140 to 180. And I want to spend a second here talking about this target, this is an important target. It's 140 to 180. Maybe there's some data that suggest below 200 is also somewhat acceptable. But I want to point on the answer A, 40 to 300. I met some hospital-based administrators who now state that the glucose between 40 to 300 is the target. And why is that? Because this is the new glycemic hospital harm metrics. And I'm trying very hard to remind my residents and fellows and nurse practitioners and hospitalists and hospital administrators and pharmacists that the true target glycemic target for most of the patients in the hospital setting 140 to 180. But let's talk about those severe hypoglycemia harm measures. So this is a metric number 1. And so severe hypoglycemia calculated by using the number of adult inpatient encounters with glucose less than 40, preceded by a anti-hyperglycemic medication. Could be insulin, could be metformin, glipizide, any diabetes medication, and divided by number of the adult inpatient encounters with more than one anti-hyperglycemic medication administered. So what it does, it counts the number of patients with hypoglycemia per number of patients on hyperglycemic medications. So this is severe hypoglycemia, glucose less than 40. And the second metric, and by the way, there are certain exclusions. So let's say if you repeated the glucose and within 5 minutes and it was less than 80 milligrams per deciliter, I mean, sometimes even in our hospital, even using the FDA approved glucometers, if you don't get enough blood and you see sugar being, let's say, 15, and like, something's wrong, let me recheck it. And you recheck it, it's 95. So it excludes those repeat glucose levels in the 5 minutes. And it's also looking at only first qualifying severe hypoglycemic event towards the denominator. So it's really only one severe hypoglycemic event is counted per encounter. And there are some other things as well. But let's talk about the next one, the severe hyperglycemia. So this is a inpatient hospitalization glucose more than 300 within the first 10 days of the encounter, minus the first 24 hours, minus the last period before discharge of less than 24 hours, and divided by the inpatient hospitalizations where patient has at least one or more of the following, either diagnosis of diabetes or administration of at least one dose of insulin or any diabetes medication, or glucose more than 200 at any time during the encounters. There are a couple other things. So what it does, it counts the inpatient hospitalizations with blood glucose more than 300 per number of hospitalization of people with diabetes and or insulin use. So there are certain exclusions. For example, hyperglycemic event is really defined as a day at least blood glucose more than 300, or a day where blood glucose test was not done, which still happens. People with diabetes come and nobody checked their glucose. And then it was preceded by 2 consecutive days where at least one value was more than 200 milligrams per deciliter. So what has already happened, and I really hope that it's happening right now as we talk right now, so speak, and that's why we're having this webinar, that hospitals will need more emphasis on reviewing and benchmarking performance in order to work on performance with ECQMs, the electronic quality measures, as we move from pay for reporting to pay for performance, which I'm sure is going to come in the future. The quality and IT teams have to build reports. We built a report. The executive team has already decided. I'm fairly confident. If you're not sure whether your hospital team decided or not on which quality metrics we're reporting, please ask them. But we should have already decided on that. So the question that I'm frequently being asked is, how should hospitals prepare? So first and foremost, if you're a hospital administrators here, please elicit the help of diabetes experts, such as endocrinologists or endocrine hospitalists, diabetes care and educational specialists, or diabetes educator, those who have inpatient diabetes management experience to form and provide leadership in the interdisciplinary glucose management or task force if none of them exist. So at Johns Hopkins, each of our hospitals has a glucose steering committee, and we all meet together once a month also to collaborate and discuss. So please get together and work together to prepare for those quality metrics and how to interpret them. What we created at Johns Hopkins, we created the endocrine hospitalist model where we have an endocrine hospitalist that's a full-time endocrine hospital, 100% full-time endocrinologist. Each of our, or most of our hospitals have an advanced practice provider. And we also work closely with diabetes educators. And of course, we collaborate very closely with the pharmacists, nurses, and dietitians. And we invest so much time in improving glycemic control and reducing length of stay, reducing readmission, and hopefully saving a little bit of money for our hospitals as well. And as an endocrine hospitalist, when people ask me what I do during the day, I say, well, of course, we spend a lot of time on diabetes and endocrine consultations. But you know what? Diabetes management in a hospital, it's not that difficult. And I find that many of my hospital's colleagues are fairly comfortable in managing diabetes. Where they are not comfortable is in discharge planning. They're still a little bit shaky about how many pens are there in the insulin box. We're still not sure that the insulin pens have been prescribed with pen needles, or they prescribe pen needles and insulin vials. But besides collaborating for other specialties and the hospital policies, if you are still thinking about deploying endocrine hospital program in your hospital, remember the opportunities for quality improvement are enormous. You can invest so much in quality improvement, and your hospital administration will love you for that. So how should hospitals prepare? Please, if you have not done it so, please reach out to the chief quality officer and some of the hospitals' chief medical officer. They are frequently tasked with reporting on quality measures. I also want to say that it's extremely important that you collaborate with your chief quality officer because they are the one analyzing the data. Maybe in your hospital, it has to be an information technology officers. And I know that many hospitals don't have a system to extract the glucose related to data present. Or we may have a system to extract the data, but don't know how to analyze it. Or we know how to analyze it, but we don't know how to interpret it. So please get together and collaborate. I'll share a couple strategies at what we've done at Johns Hopkins. So we created our glucometric dashboard a while ago, where we can compare all of our hospitals. So this is the Johns Hopkins Baby Medical Center. This is Johns Hopkins Howard County Hospital. This is the main campus. This is Suburban Hospital. This is Sibley Memorial Hospital in Washington, D.C. Those are the key 5 hospitals which are in Maryland and D.C. We have one more hospital in Florida. But we can all compare each other. And for example, this Suburban Hospital, we can see whether the hypoglycemia. So this one particular one is glucose less than 70. And strategies, how we deployed. And that's how we compare every single month between each other to see how we're performing. And there are other companies which can help you to get those glucometric and the software developers. There's a Glytec, and there is a Monarch Medical Technologies and the Medical Decision Network. And there are some other organizations, including the CDC, which are looking and helping hospitals to deploy those hypoglycemia metric and get the data from the hospital. Our hospital did not participate in any of the third-party glucometric software. We did not participate in CDC. We created our own glucometric. But if you don't have many resources, I think it's a decent strategy to collaborate with the third-party glucometric software developers. So remember the slides, what I was showing you? Obviously, the data is already publicly available. I did not display data here yet because I'm not sure I'm completely trusting yet. But hopefully later this year, there will be more publicly available data on ECQM metrics comparing all of our hospitals in the United States. But what you have to pay attention, and if, again, they're hospital administrators, if you don't report, you will be penalized. And those financial penalties are going to be different between different hospitals, but they're going to be sizable enough for hospitals to feel it. So I would like to share some of the projects and some of the quality improvement project at Johns Hopkins Medicine, where which we appreciated some potential impact on the glycemic outcome. So one of my first projects was a reduction in hypoglycemia at Suburban Hospital and Bethesda, Maryland. That's where I spend most of my time. So for example, we realized as soon as I created an endocrine hospitals program that, and we had a lot of hypoglycemia. It turned out that we didn't have a unified hypoglycemia protocol. The hypoglycemia rates were like 7-8%, a lot of hypoglycemia. We also found, for example, that our insulin infusion protocol was still set to glucose target of 80 to 110, and virtually every single patient in our hospital who was placed on the insulin infusion protocol would develop hypoglycemia. We also switched to insulin pens, and we reduced the hypoglycemia. And if you ask me, is this a big deal? Perhaps. Over 17 months, we were able to save about $100,000. And hospitals definitely, especially hospital administrators, definitely appreciate those cost savings. I'll give another example. When our endocrine hospital has grown, we were able to open a second endocrine hospitalist program together with my colleague, Dr. Andrew Demidovich. So this is hyperglycemia at Johns Hopkins Howard County Medical Center in Columbia, Maryland. This is when the hyperglycemic rates were managed by the local endocrine group, which were terrific. But here what happens when you bring a full-time endocrine hospitalist, he's Andrew Demidovich, and his advanced practice provider, Kristen Batty, who unfortunately left us. But she's helping another hospital system right now to deploy a similar initiative. We also believed in the A1C for diagnosis of diabetes. Quite often, many of our institutions don't even recognize that A1C is so important. I want to give some shout out to Sarah Khan from, she was a fellow at the Johns Hopkins Hospital. Now she's an assistant professor at the University of Maryland. So what we've done at Suburban Hospital, nobody would check A1C, nobody cared about A1C. So we created a quality improvement project, when we encouraged the hospitalist and the pharmacist and the nurses to order the A1C. And we had a statistically significant sustained improvement in frequency of A1C ordering. I'll tell you in a few minutes why this is important, because I suspect, well, I'll tell you in a few minutes why. So what do we do right now? And if you haven't used, we're using a machine learning tool, which is embedded in our insulin order set in Epic, where if there is no recent A1C, it's auto pre-check. So every single person who has a A1C insulin ordered, even if it's just an insulin correctional scale, it would automatically add on A1C if there is no result available in the system. It would not draw a new lab, but it will add it on. And of course, if the recent A1C is available, like here, the recent A1C 10.9% will not add it on, we'll just display it. One of my favorite tools is a glycemia rescore in Epic. It's available to everyone. I know many of you are using Epic. It can add a little red circle to your list. So when I come in the beginning of the day, I can quickly stratify my patient by the glycemic rescore. It can be 40, 10, 20, 10, or 0. And you know quickly on which patient you need to jump in to see them sooner. And it will calculate the glycemic rescore based on whether we received any diabetes medication recently, whether we had a hypoglycemia or hyperglycemia. I love this tool because every day when I come in to Suburban Hospital, I run a quick report who had hypoglycemia in the past 24 hours in my hospital. And if I see that we had a high glycemic risk score, that means that they probably received some anti-diabetes medication. I send a quick security chat to the hospitalist, to the surgeons, like, hey, Dr. Amin, I noticed that your patient's sugar was moving to 50. May I please help you with his severe hyperglycemia? And most of the time I get a message like, oh yes, please, of course, please help me out. And of course, sometimes like, oh no, we're okay. We noticed we're changing the insulin orders, or no, we actually transitioned this patient to hospice. So if you don't have a glycemic risk score in Epic, maybe it's already part of your toolbox. You just have to locate it. If you don't have it, just call your Epic administrator, your chief medical information officer, and ask him to pull it in from the library. I want to talk about the future. So right now, we've been talking about pay for reporting, and it's true. Hospitals who fail to report by fiscal year 2026, by 2028, we will have to pay for not reporting, but I'm not going to be surprised. In a few years from now, those ECQMs, those hypoglycemia, hyperglycemic quality metrics will become pay for performance. And I know that CMS and other organizations, including the state of Maryland, is looking for other possible measures to track hospitals. And one of them is hemoglobin A1C. So that's why I said a couple of minutes ago, like, let's talk about it. So I know that the state of Maryland is looking into adding A1C as one of the trackable way of looking how hospitals are performing. Are you measuring A1C in all patients with hyperglycemia, glucose more than 140 in the history of diabetes? If you are, then you're doing great. And if you're not, I also want to say that the recurrent hypoglycemia and time in range are two other things which CMS and other organizations are eyeing to see whether they should be measured and reported. The question I frequently get from my colleagues, especially outside of the United States, when I share those things that are happening in the United States, like, well, are those performance measures even effective? I don't know. We know that the national programs to assess the quality of care for sepsis, acute MI, heart failure have led to significant improvements in evidence-based care. So similar measures introduced to standardize the use of VTE, prophylaxis hospitalization in the past led to development of anticoagulation task force. I remember then when heart failure measure just came out, we were like, oh, okay, that's what we have to do. Or MI measures or sepsis measures. I mean, sepsis is a huge part of mortality. I think that you walk in any hospitals, the hospitals know, get the lactic acid, get the fluids, get the antibiotics going. And those measures plays a huge importance in reducing hospital mortality. So I really hope that the need to obtain the reported CQM glucose metric will inspire the hospital system to develop similar task forces and action plans. And I hope your hospital will be the winning hospital. We also know that performance-based models are not just for Medicare. Even though many of the past programs mentioned above were really originated from the Medicare and the CMS, the commercial insurers have also moved towards performance-based payment models subsequently. And the proponents of the value-based model argue that having those benchmarks for performance will help prioritize quality over quantity of care. I'll repeat again, having those benchmarks for performance will help prioritize quality over quantity of care and helps to encourage those best clinical practices. And when I ask myself, why did I become an endocrinologist? Did I become an endocrinologist, an endocrine hospitalist to see as many patients? Probably not. I love seeing patients, but I think the quality of care is more important. But also, it encourages the accountability and transparency. Remember that competition for this reporting system is important. That, as I said before, the pay for reporting system is likely to transfer to pay for performance model in the future. And similar pay for performance models have been successful in reducing undesirable outcomes such as 30-day hospital readmission length of stay. At the same time, I also have some concerns about performance measures. The key concerns is that the system stems from potential harm to hospitals which serve socioeconomically disadvantaged populations. So hospitals that treat a large volume, low-income, high-risk patients who struggle to engage in the healthcare system to start with may not perform well on the pay-for-performance measures, and in turn may avoid treating such patients. So I even speculate that such measures could reduce even job satisfaction. Hey, who likes reporting more, and lead even some provider burnout. And of course, data extraction, data availability, it's not free. Administrative costs to develop automatic system can really gather and verify necessary data, also substantial. And I also suspect that glycemic metrics are not always going to lead to glycemic outcomes. So you're going to get the data. Great. So now what? Hospitals will produce those fancy reports. What are we going to do with them? The hospitals will still have to figure out how to interpret the data and translate this data into actionable items. And I want to say that the challenge is that all data, critical, not critical care, will be lumped. And by the way, what about this glucose of 54 milligram per deciliter? Or is this going to be tracked? Is someone going to care about glucose of 54? I care, but would you say, oh, Medicare is like, well, they only care about glucose less than 40? What about glucose of 275 milligram per deciliter? Is this considered severe hyperglycemia? What do you think? Well, I don't know. I hope that people not gonna just pay attention to glucose less than 40, more than 300. I hope that people really understand that the glucose of 54 is important, still considered hypoglycemia. Glucose of 275 has to be addressed as well. All right, I'll summarize my talk. So the key to success with a new ECQMs, new electronic quality hospital measures with glucose less than 40 and glucose more than 300. The key to success will depend on how hospitals choose to partner with endocrine hospitalists, diabetes expert, quality information technology officer, physicians, PAs, NPs, pharmacists, nursing staff, so they can all incorporate those new metrics into the quality improvement initiatives. Remember, the goal is here not to reduce only hypoglycemia or only hyperglycemia. The goal is here to balance hypo and hyperglycemia. Ultimately, you have to standardize the quality of diabetes care across the nation. And the high performance of these metrics will help the hospitals to make a step forward, becoming a high reliability healthcare organization, and ultimately make sure that the mistakes when patients get 10 times more insulin than they should have not happen, and making sure that our hospitals become safer for people living with diabetes. I want to again thank you so much, Jordan. Thank you so much, Melissa. Thank you so much, Leapfrog Group, for invitation to share my passion about diabetes care. I'll stop here. I want to say thank you, and I think we have a few minutes for questions.
Yeah, thank you so much, Dr. Zilbermint. I'm going to take 10 minutes and hand off one of the pearls that you talked about there. Certainly a fantastic summary of the ECQMs, how your system is driving change. And I want to take one of those nuggets when you talk about how we can use data to drive change, how that data can become actionable insights. So I have about 10 minutes to just let's share a little bit more of that piece there, and then we'll have some time for Q&A in the last 10 minutes. But yeah, really continue to put questions in the Q&A. There may be some in there, Dr. Zilbermint, that you can answer while I'm talking here. I want to talk a couple of minutes just about us at Glytec. So at Glytec, we do have Glucomander. We have insulin software to help manage insulin at the point of care, IV and sub-Q insulin. We have an FDA-cleared product to help manage IV and sub-Q insulin safely in the hospital. And I want to spend a bit of the time here to talk about analytics. We have a command center feature as well to give retrospective and real-time analytics. We've been around for about 20 years, Glytec. Again, our software is Glucomander, as well as this command center. We have FDA-cleared solution in about 400 hospitals around the country with numerous papers on our website showing our data. But I wanted to talk about that data because the only way to really improve is to have data. The reason that we exist is that there's still a challenge in glycemic management in the hospital. We know on a lot of projects that we work on in the hospital, there's a big gap between what we know and what we do, this implementation gap, for a variety of reasons, whether it's lack of awareness, standardization, and I want to talk a bit more about the metrics and carry that piece when we're talking about these ECQMs, the less than 40 and greater than 300. The call to action in glycemic management has been around for 20 years, and we still have this gap. And you hear again from Dr. Zilbermint all the variety of great strategies to continue to improve care. How do we close that gap? We know from the guidelines how to manage insulin safely in the hospital, IV insulin for critically ill, basal bolus for non-ICU. Yet we still tend to avoid IV insulin in certain situations. We still have a very reactive approach of sliding scale and often don't make daily adjustments to insulin. And then you wind up with blood sugars that look like this for patients, sort of a roller coaster ride, a reactive approach, and not managing this safely. And there's data around this, particularly for IV insulin, when you're not standardizing care, when you're going off protocol, there is preventable hypoglycemia. And using computerized programs can help reduce that error rate. And a lot of these errors are from going off protocol, often not justified. We again have evidence that there is a preventable hypoglycemia that occurs with management of insulin in the hospital. So to talk about the data challenge too, there's a gap here as well. And you just heard about some of that gap that hospitals have, lack of metrics, lack of resources, even when you get the data, lack of what to do with it. So we know a lot of our health systems have some basic rates, basic hypoglycemia rates. Now with CMS, we have more information, or at least around less than 40 and greater than 300, but we want real actionable insights, right? We just don't want those two measures. We want to know, is our hypo driven by renal patients? What's happening with the management of our DKA? Are we using our protocols? When I'm managing basal insulin, did I adjust it? And we know that a lot of hospitals don't have meaningful glycemic outcome data because there's a lot of noise, and trying to get some real signal out of that, trying to get some actionable data out of that is challenging. And this is another call to action that's been out there for 10 plus years from Dr. Maynard, a colleague, a CQO in California. Every hospital should prospectively monitor and measure rates of hypo and hyper, insulin use patterns, coordination of insulin administration, glucose testing, nutrition delivery, and getting real-time institution-wide glucose reports. And we're finally getting somewhere with the ECQMs, but there's so much more that we know we should be doing. So how we're thinking about it is how can we get this data and refine it so that we actually can make the right decisions and actions in real time. Not just the retrospective data, which again, less than 40 and greater than 300 gives us a start there, but how do we even get real-time data? And when we're thinking about data, we're thinking about it in different categories, not just these glycemic outcomes, but the process metrics as well. making sure we have, balancing metrics to these as well. And I think the process metrics are a big part of that's often the gap to understand those actionable insights. And just as an example, if you are working on an improvement project and you've seen a lot of sliding scale only, SSI only on the left, and not much basal bolus, you want to be able to track if you're doing improvement, that basal bolus is increasing over time. And often we don't even have that simple metric. And even beyond that metric, if you're going sliding scale, basal bolus, okay, once you get your team doing that, are they actually doing the correct starting doses? Or after they're doing that, are they editing doses following excursions, lows or highs? Okay, so here we are, less than 40 and greater than 300 is a start, but I know you want to know more, right? You want to know more insights, more metrics. Even if we pick one of those, we want to know more aspects of just the less than 40. And you heard some of that from Johns Hopkins, how we have hypo risk scores. So at the left side, on the unrefined area, maybe we're able to get less than 40 last month in our health system, but can we start getting a little more refined, at least by location? How many of those less than 40 are truly related to insulin or not related to insulin? That would be a nice refinement to get. And certainly how we compare to others, which again, these ECQMs will begin getting there, although that's not the intent, but we want to know how we compare before a project, how we compare to others. And then really, the actionable piece, like why are we having those less than 40? How can we tease that out of the data? And then the real-time piece, how many today are at risk for less than 40? And then really thinking about the future, why I should be able to know how my health system works and get a sense of how many less than 40 I might have next month. So that's just one metric, and thinking an evolution of refinement. You have, I'm sure, a lot of these types of glycemic questions. And just a quick example before we wrap up here, this is how we're thinking about it. If you understand some top reasons for hypoglycemia, I won't go through the list, but you have a list of reasons why it might be happening. If you could just show in real time the 70 to 100, and we know almost 40% of these patients with 70 to 100 will wind up having a hypoglycemia. So imagine if you had a list in real time of those 30 patients, and you can populate that list quickly to see who those are. And then maybe a next iteration is you can refine that list further, that I know 10 of them have developed acute renal failure in the hospital. 10 of them have normal A1C and just stress hyperglycemia. 5 of them on an oral medication to reduce blood sugar, and 5 of them maybe on an unintended target range. And then maybe either further refinements over time, you can get some more clarity about, for example, one of those patients with a normal A1C, that their insulin total daily dose is now low, and maybe there's a recommendation to stop insulin. So we're thinking of these kind of refinements. How do we go from basic metrics to predictive models? And you saw one example, real-time analytics, really future state, thinking about AI-driven innovation, and then even shaping metrics, not just the individual patient, but as business strategies. So these areas around predictive analytics, we're going to have to think in the future soon. CGM data is not FDA cleared for inpatient use currently, but it's going to happen. How do we build AI tools to personalize these insights? How do we think about other strategies we're doing? Patients on insulin are often not candidates for hospital at home. And we're really trying to think for how can hospitals have a command center for glycemia insights to get real-time insights to help them optimize, obviously, patient safety, but rounds and workflows. So a lot of exciting things thinking about that space. Really thank you for your time here. A lot of amazing information. I know you heard from Dr. Zilbermint, just even teasing one improvement area around metrics, because we know we can't improve if we don't measure. We're at 1:50 now. We've got some time for questions. Melissa, who's on our Glytec team, has been reviewing the Q&A. So let me pause there and see what questions we have from you all.
Excellent. Thank you, Dr. Messler and Dr. Zilbermint. The first question that popped up is, what would you recommend for diabetic patients receiving steroids to help prevent hyperglycemia?
This is an excellent question. I think that the best strategy for those patients is probably to use NPH insulin to be administered together with steroids. There are multiple papers addressing it. Feel free to email me and I'll share some of those strategies. My personal preference is to use NPH insulin. Alternatively, you can calculate the higher insulin total daily dose rather than using, let's say, 0.3, 0.4 units per kilogram per day. You can use 0.5, 0.6, 0.7 units per kilogram per day and give 30% of that insulin as basal and 70% of that insulin as nutritional divided into 3 doses.
Excellent. Thank you, Dr. Zilbermint. The next question is, do you see CMS eventually tying payments to actual performance on glycemia, not just reporting? And what does that mean for us financially?
Well, nobody knows for sure, obviously. I speculate that this is going to happen in the coming years. And financial is going to mean different things for different hospitals. I think depending on the performance, if you're performing very well, your penalties could be little or none. And if you're underperforming or you have a lot of severe hyperglycemia, I wouldn't be surprised that hospital will start penalizing, the CMS will start penalizing the hospital the same way they're penalizing hospitals who have high sepsis or mortality rates.
Yeah, can I just add to that too? I think that's right on. You know, I think we already saw a progression from these measures being elective to recognizing that you can't just report one or the other, that you have to report both. So that's why they've already evolved from elective measures to starting 2026 data as mandatory. And this is a space that I think you'd agree we're going to likely continue to see variation. And if CMS sees these measures, not everybody's going to suddenly be at 0%. There's going to be a lot of variation. And I think that's historically over time, you know, it may take several years, they'll see that variation persist and some outliers, and then it may very well be a pay for performance and not just pay for reporting.
Excellent point. Thank you. Another question is, we don't have dedicated endocrine hospitalists. How realistic is it for smaller hospitals to implement that model, and what alternatives should we consider?
Yeah, I think that if you'll ask me if I would put a stock into endocrine hospital, I think our field is definitely going to bloom in some time in 2008 when hospitals will be hit with the penalties and we're gonna, oh my God, I should have done it years ago. So I can say that Suburban Hospital, where I started endocrine hospitals, is a small hospital. We're only 240 beds hospital. So it's completely real. It's actually much easier to do in a smaller hospital rather than trying to implement big program in the big academic centers. My suggestion is the following. I tried to recruit an endocrinologist who recently graduated, who is still very enthusiastic about teaching and running around and sharing strategies, who would, rather than spending all of the time in the outpatient setting, would consider spending the time in the inpatient settings. And my first question was, oh, do I have enough patients to see? Trust me. In a 200-bed hospital, we know that every 4th person who walks into this hospital has diabetes. So at least 25% of them would have diabetes, and our hospitals are pretty full. So try to recruit an endocrinologist who would be passionate about inpatient diabetes care.
Excellent. Thank you so much. Another hospital says, we have a lot of glucose data, but it just sits in reports. What would you suggest as the very first thing a hospital should do to make that data useful?
Ooh. I'll tell you, if you are completely, like, oh my God, I don't know what to do with this data, I don't know how to analyze it, feed it into ChatGPT and ask them to run some reports for you. You will be surprised how it will help you to analyze the data very quickly. That would be my simple recommendation. But obviously, if you have an analyst or data analyst who can help you with some other strategies, you can come up with a question and try to answer it. My favorite part in our dashboard, and I know that Jordan just mentioned their dashboard as well, is we can really zoom in on the unit. So last year we realized we had a lot of hypoglycemia in our cardiothoracic unit. So we decided to do individual chart review rather than all of the patient chart review. And we were like, yeah, they're probably giving them a little bit too much insulin. And we were able to tackle the challenge, re-educate the nurses, and now the hypoglycemia rates drop there.
Yeah, I just add to that too. You know, it's a common question in a lot of different quality improvement projects, right? You have some data and not necessarily acting on it. Certainly the first steps also is just like for quality improvement, like be clear on the goals and be clear that you have a team, a glycemic team to look at this. And potentially, you know, that team needs to be accountable, someone, an executive, so other folks that are looking at these measures. And I think, like Dr. Zilberman mentioned too, sometimes you feel like you have a lot to chew. Like, start narrowing down, pick an area. Certainly a surgical area like CABG, who recognize the importance of a glycemia, is a great one to start with, but you might have to narrow down. Or, you know, some organizations will come to us, places like us that have technology to help analyze your data also.
Excellent. Thank you both. And one more question. I think we may have time for an additional one, but let's do this one for sure. When we pitch glycemic safety to our CFO, where's the clearest evidence that it actually saves money? Readmissions, length of stay, nursing time, or something else?
A little bit tricky. Here's my recommendation. If you're deploying endocrine hospitalist role, or you have a clinician such as an endocrinologist, leverage ability of endocrinologists to see consults, because when endocrinologists see, or other special nurse practitioners, PAs see in the consult, they can generate RVUs or relative value units. So build the insurance so they can generate offset some of the costs associated with paying for someone's salary. And in the first year, it's very hard to appreciate the reduction in hypoglycemia or 30-day readmission or length of stay. It really comes in maybe in a year or two, a little bit later, because you need to deploy hospital-wide initiatives. In our hospital at Suburban, our initial study, we actually found that the biggest cost was associated with length of stay. But in other places, it could be biggest cost saving could be associated with 30-day readmission. But we always leverage the ability to see consult and generate the revenue this way as well.
Excellent. Thank you so much, Dr. Zilberman. And Dr. Messler, this one last question for you. Medication errors with insulin are one of our biggest worries. What are the top 2 to 3 practical steps we can take to avoid insulin errors in real time?
Yeah, you know, when I think about quality improvement, we certainly think about people, processes, and technology to help improve. You know, there's certainly processes, as we mentioned, to standardize care, reviewing your policies, data to review, try to understand the top reasons why, and then leverage technology. You know, we certainly are a company that leverages technology to help reduce insulin errors. But I think, you know, there's a variety of strategies to really help make sure you understand why it's happening. And then solutions, you heard a bunch from Dr. Zilberman, several from me around metrics, and then leveraging technology.
Excellent. Thank you. And it looks like we are right at time. So I do want to take this last few seconds to say a tremendous thank you to both Dr. Zilberman and Dr. Messler for joining us today for this exceptional webinar on this very important topic. So I hope everyone has a great day, and we'll see you on our next webinar. Thank you.
Thank you all. Take care.